Diamonds, it's Dr. Sonia, and I am here. I am so excited. I am so excited for this podcast episode. I have the amazing Dr. Kelly Casperson with me. If you don't know her, now you know, and you definitely need to know all about her. So, I'm actually going to have her introduce herself because I'm not going to do justice to all the things that she is about. I can tell you she's a magnificent urologist. She's an author of an incredible book called You're Not Broken. And also she is a TED Talk speaker. And I know there's even more. So, Kelly, I'm going to have you introduce yourself, and then I've got all sorts of questions for you.
Thank you. Thank you so much. I'm a urologist. I trained in Minnesota, which you know and love because that's where you practice. Went to the University of Minnesota for med school, and then did residency in Colorado for urology. Was about 7 years into urology practice when I had a life-changing patient, basically changed the trajectory of my life because it's got me curious about female sexual health, sexual dysfunction. What do we know? What don't we know? And I just dove deep into that, got into coaching because of sex, basically, and then started a podcast 3.5 years ago. It's doing amazing. TED Talk, book, helping all the people.
So good. So good. I asked you specifically on this call because I want to talk to you about GSM, General Urinary Syndrome of Menopause. I think that
we have to talk about this.
It's well past the time. I was about to say the time has come to talk about it, but it's well past the time to talk about it. It should have been talked about like hundreds of years ago. Like it should have been.
One.
Yeah, exactly. So at this point in time, for everybody that doesn't know, and even for those that do know, tell us, what is GSM?
Yeah, GSM is the rebranded vulvovaginal atrophy. So GSM is Genital Urinary Syndrome of Menopause. There was one urologist at the table when they rebranded this. People didn't like how atrophy sounded, plus it didn't describe why it happened, and it didn't encompass everything that happens in the pelvis with menopause changes. So Genital Urinary Syndrome of Menopause tells you why it's happening, and it's basically what happens to the pelvis when our hormones go away or change. Not everybody loves GSM because GSM-like symptoms can happen when you're pregnant, when you're breastfeeding, when you've gotten cancer treatments or radiation, when you're on birth control pills, right? So there's a lot of these symptoms that can happen because of low hormones, not always just because of menopause. So now people are like, I don't like that you're limiting it to menopause. And I'm like, people just need to know. Before vulvovaginal atrophy, believe it or not, it used to be called senile vagina.
Oh, my goodness.
Yeah. So we're continuing to get better. Yeah, I actually researched that. So I went down this rabbit hole, like tangent for a second. I went down this rabbit hole because I was so sick of the internet saying use it or lose it. And I was like, where did that come from? Show me the evidence, right? So I actually went back, had a medical librarian be photocopying old journals of the one crappy study which did not prove use it or lose it. But in the 80s, they were calling it senile vagina.
Senile vagina. Seriously? There's a lot of senile going on, but it has nothing to do with the vagina. It has to do with people choosing these words and not really being there to help women.
Yeah. So we've come a long way, baby.
We have come a long way. We don't need to smoke a cigarette either in order to come that far. So, exactly. And that's a reference for people that might be
people who didn't pick up on that one.
Well, it used to be for a Virginia Slims commercial back in the 70s. So you had to be like in your 50s or older, but it was a cigarette that was marketed to women, and it was a really long, thin cigarette. Like thin is better in all things except your vulva. You don't want that after being in thin, right? But yes.
And if a physician who went through medical school, who then did 6 years of pelvic surgery training, didn't know that labia minora resorb or go away or dissolve or whatever word you want to call it. I just thought all these women in their 70s were born without a labia minora because I do tons of exams, right? And it wasn't until I went to an ISWISH conference. The ISWISH is International Society for the Study of Female Sexuality, basically. They do a fall course for any provider who's interested in this. It's exceptional. one of the lecturers was like, yeah, and you can see the, genital structures dissolve or go away with low estrogen. And I'm like, I'll be damned. Nobody ever told me this. I just thought they were born without them.
So basically, like people born in 1941 and earlier, or 1950 and earlier, for some reason didn't have a labia minora. Like this is, and the fact that we're not taught this, this is the real concern. People think that medical doctors know a lot of information about women's sexuality and their vulva, and we're not taught in medical school. And if you've gone 6 years of training in pelvic surgery and things like that, and you still didn't know that, I mean, we need to be aware of this, and we need to be talking about this everywhere. That's why we're talking about this today. So thank you so much and joining me here in this conversation.
Absolutely.
Thank you. Yeah.
When recurrent urinary tract infections are in the top 10 reasons that people go to their primary care doctor, right? This is a huge problem. We have a medication that decreases UTIs by 60%. It's called vaginal estrogen. And, I hear over and over women go to the doctor like, why do I keep getting these recurrent urinary tract infections? And the doctor's like, I don't know. But it's like when you lose estrogen, your pH changes, your vagina is less acidic, so you don't have a healthy microbiome. Your labia resorbs, your urethra becomes less protected, and your urethra gets pronounced outward, what's called telescoping, right? Yeah. Not protecting it from the micro trauma that happens down there. And so it's like, once people understand it, it makes perfect sense why these people get way more urinary tract infections than your, 25-year-old.
Exactly. And we need to be aware that a urinary tract infection is not a minor thing. Like this can lead to some major health issues. Right. And so this is like, if we are focused on the preventative side of things, then we prevent the urinary tract infections. We can prevent sepsis. We can prevent a lot of things that are happening that we're just not addressing, especially when it's women's overall health and definitely their vulva health as well.
Yeah, absolutely. I mean, people die because of urinary tract infections.
Exactly.
And I like to tell people this, like, the only people who never get a UTI are like dead people, right? I can't make you never have one, but our goal is less and less. And we know that just taking an antibiotic makes you more susceptible to another urinary tract infection because you've killed your microbiome, right? Yeah. And so it's like trying to space these out, decreasing your risk, optimizing as much as you can.
So good. So important. Why is nobody talking about this? Why?
I just posted like the clitoris has no place in the current medical paradigm, right? Of like either does the labia minora, but I think we are starting to talk more about prevention for UTIs. I think we're starting to talk more about hormones, which is good. I think female sexuality is really not discussed besides the disease and pregnancy part of it in the medical paradigm. So I think that's part of it, because people are like, oh, what's such a big deal about vaginal dryness? And I'm like, have you had dry eyes? Have you had a dry mouth where your tongue's like sticking to dryness is very bothersome. And I think, a lot of it gets dismissed, but the amount of like vulvar itching, perianal itching, that is all low hormones, like the suffering is real. And I think our tolerance for female suffering is a lot higher than our tolerance for male suffering. I'm a urologist, so I see it all the time. Like, oh my God, your testosterone's low. Here you go, have some testosterone.
Right.
Whereas in women, we're like, are you suffering enough?
Right. Is it just a little something? What? Why do we need to really address this? So you are a urologist, and I love that. And I'm going to ask you about something like this blue pill, right? So it's being prescribed all over the place. And blue pill, I mean Viagra and the other type of medications that are out there. When you're like somebody comes to you and they're looking for this blue pill, the majority of people that are coming to you are probably heterosexual. And then there's going to be another person, another partner, female in this instance, if they're heterosexual. And are you having discussions with about their counterpart? Is there anything going on with their partner? Is their partner having any problems? Things like when somebody comes and asks you for the blue pill, is it just a matter of prescribing the blue pill, or being that you are Kelly Casperson, do you go a step further?
Well, yeah, they get me now, right, and all of my training. But for the longest time, it was like, you have erection issues, here's the little blue pill. or it's cousins, right? And I think it's fascinating because I've talked to other urologists about this. Like, I actually want to see a debate on if you give Viagra, should there be a conversation about if your goal is partnered sex? Is your partner being cared for as well? Because how many stories do you hear where the woman returns the Viagra, the woman's mad at the doctor for giving Viagra, and a lot of urologists will tell you, I'm treating the patient in my clinic. It's up to them to, have those I'm treating the person in front of me. The person in front of me wants an erection. And now that they get me, I'm like, what's your partner? What gender, blah, blah, blah. Do they want an erect penis in their life?
Has anybody asked them?
Right? I know. Have you asked? And so now I ask the guys this. And I'm like, 9 times out of 10, they've not even talked to their partner about their plans for a super penis.
Right. They have not talked about it, right?
What is your plan for the super penis?
The super penis has arrived, but, is anybody, it's got like a little cape on and it's ready to go. And everybody else is like, it's a bird, it's a plane, it's an erect penis that I never asked for. Could I have a Gucci day? Right?
Yeah. Maybe she was perfectly happy not having a penis in her vagina. And certainly if you're past, 40% of men will have erectile dysfunction by age 40, according to the Cleveland Clinic. This is a big problem. It's not talked about enough. But is she being treated? Is she on vaginal estrogen? Is sex comfortable for her? Is it pleasurable? Does he care about her pleasure, or does he just care about his erect penis? So certainly I put a lot more, I tell guys, I'm like, I'll give you Viagra, but you need to communicate. Like,
it's almost like it should have a cosign, like if you go to buy property or something, you have to co-sign it with your partner. There needs to be
if you want to put it in a vagina.
Exactly.
Like if you just want to get it hard by yourself, like go for it.
Go for it, right?
Yeah.
Yes. Yes.
But don't go in assuming she's going to welcome you with open arms if it's been 8 years.
Mm-hmm. Yeah, or longer. Yeah, very often this is a number of years, and then all of a sudden,
very often it's years.
And then it's a whole different thing. Yeah. So
and believe me, like to me, I'm like I am on team people wanting to have sex. Like believe me,
I'm 100% there too.
You are an adult, and your communication sucks.
Yes. There it is. Because as you say, like this is impacting at least 40% of women, of men or more. And yet very often their partner doesn't even know why sex stopped, because they didn't even admit to their partner that it has to do with their penis not working the way they wanted it to. So their partner's over there blaming themselves very often, has no idea what's happening. And suddenly Mr. Super Penis shows up. But now there's layer upon layer about all these thoughts and feelings that are there because there hasn't been sex for a year or longer. And the partner has spent the large majority of that time thinking that there's something wrong with them. And because this communication is not happening. And now all of a sudden, it's almost like super penis has arrived. And now we will resume what we were doing before, right? But there's a year or more in there of thoughts about maybe I'm not attractive anymore, maybe like this is even if their body's functioning, their vulva health is 100% where it needs to be. But now they have all these thoughts in their mind because their partner never told them exactly what was going on. And so they've had to come up with reasons and ideas. And very often female partners tend to blame themselves when things are going wrong.
That's right. We don't know why, so we create stories in our heads.
We do.
Usually which are mean. Yeah, I think communication's number. Yeah, like communication is key, and I don't see a lot because our sex ed is so bad, in the country, in the world.
It is.
But communication is very important.
So you talk a lot about adult sex ed, right? And that we need to do a do-over, basically. Like there's all these rules and laws, and each state has different rules and laws about sex ed for teenagers or people in school, right? So there seems like there should be some sort of mandatory adult sex ed. So talk a little bit more about that.
Yeah, I mean, I don't really know where this concept came to me, but it was like, and it turned into a TED Talk. That's how much I care about it now. But it's like we really did get a disease and pregnancy prevention plan. If you're lucky, you got that, right?
It wasn't. It wasn't a very good one. It was like, don't do this, or don't get pregnant, and you don't even know how to get pregnant. So how are you supposed to figure out how not to get pregnant, right? So.
Yeah, absolutely. And so what we've done is we've tried to fill in the gaps with Hollywood movies, the top 10 country hits, porn is becoming more and more ubiquitous. 30% of the internet broadband use in this country is porn downloads.
Yes, 30%.
It's at least 30.
Like at least 30%, right? So basically,
so we're getting a sex education. It's just not accurate.
It's not accurate at all, right? And yeah, I mean, I don't necessarily say porn is good or bad, but it is fantasy. It is entertainment. It is not actuality, right?
Yeah,
so
it's
we
production.
have, yeah. And then usually by age 10, most kids have at somehow like, even if they were like looking for Minecraft, just Googling Minecraft, suddenly it's porno Minecraft that comes up, right? So they're going to get exposed to this at some sort of age, right? And by the time we're an adult, we have many years of being exposed to this in one form or another, and it's not accurate. And so now this becomes the basis of what we think sex and sexual intimacy looks like, right?
Yeah.
And it's a lot of pounding. It's a lot of penetration. There's not much talk about the clitoris and, foreplay and everything happens in like 3 seconds. So, yes.
Yeah. I mean, it's pretty bad sex education, right? And it certainly doesn't teach you how to communicate. And it doesn't teach you how to talk about uncomfortable things and when things go wrong and like all the good stuff.
Yes.
But I'd say all the necessary stuff if you want to have a sex life continue through the years for you. Right, because inevitably there's going to be health issues and there's going to be menopause and there's going to be erectile dysfunction. Like if we don't talk about it when it's good, that'll set us up for, not being able to talk about it when there are some issues.
And there's going to be issues like what percentage of people do you think make it through life without any issues at all around sex, sexual intimacy? Like,
0.
Yeah, I would say 0.
4.
Right? And even if you think there's no issues, there's issues.
Somebody on Instagram, they're going to be like, I'm 82, I've had no issues. I'll be like, nice to meet you.
Nice to meet you, right?
One of you.
They're also like, I haven't had sex either, so.
Right. Yeah.
Yeah.
It's incredibly, it's just like normalizing it, for people of like, you guys, this is hard for everybody. Mm-hmm. There aren't unicorns. Like, this is a skill. It's okay.
Yes, 100%. So if you had a do-over for sex education for adults, what would you make sure is in there? It sounds like a communication course. What else would you put in there?
Well, it's the biopsychosocial, right? So bodies, how our bodies work, how that clitorises are important. They're as equally as important as penises are in the role of pleasure and arousal, that everybody has erectile tissue, how dopamine works, right? We only seek out things worth desiring. So if your sex is crap, don't expect to desire it. So bio, and then psycho is your brain, your thoughts about sex. Is sex bad? Is sex for you? Is sex too hard? Is sex dirty? Right? Like all of the brain thoughts, that's where all the good coaching comes from. And then social is, inequality, unequal work distribution, who's allowed to desire, who's not allowed to desire. The amazing paper on low desire and the heteronormative theory of low desire in women partnered with men. Like, is it insane to anybody else that the people having the most orgasms are the heterosexual men and they're partnered with the people having the least amount of orgasms, which is the heterosexual female? Like, that's insanity, right? So we need to teach. I'd love to teach about that. So it's really like the biopsychosocial. And that's what I put. I did a master class online. You can get it at my website. Like kind of a primer to adult sex ed that's like, it's not hours and hours of stuff. We just need to solve some simple problems, give some simple education, empower people to communicate, and you're off running. Know that you can try and fail and try again and fail, try again. And you're off and running.
So good. I like that. Try again. Just try again. You don't have to make it mean anything. Just figure out what you like, what you don't necessarily like. Make sure you get the information that you need. I wanted to circle back to GSM because we didn't talk about the incredible vitamin that everybody should be taking if you have a vulva or a vagina, the vitamin E. Can you talk a little bit more about that?
So everybody's going to go buy vitamin E now. It's estrogen.
Vitamin estrogen, exactly.
Vitamin estrogen. Well, it's over the counter in a lot of countries, and I
Isn't
like
that
to say that
amazing?
because not. It's amazing, I don't think that's coming. We still have a very scary FDA black box warning on vaginal estrogen, which we are actively trying to get removed. That already failed once in 2018. So I don't see this going over the counter anytime soon. But the good news is the price is dropping, and there are
Good.
some really great online pharmacies. The Mark Cuban Cost Plus Drugs, $20. Amazon Pharmacy, $20. Nobody should be paying. The GoodRx coupon, GoodRx app on your phone should be $20 to $30. Nobody should be paying more than that for their vaginal estrogen, because this is a lifelong. This is like, it's not like you put on sunscreen once and then you're good, right? It's a skincare, and it's
Yeah.
skincare for life. I used to tell people use it until you die, and I think they thought I was too morbid. So now I tried to lighten it, and I say use it 3 days until you die. You get a laugh out of it, right? It's like, if you're gonna die in 3, you should stop.
It's like, oh well, I only got 3 days, but just in case,
Yeah.
just in case the estimate is not correct, you might want to just continue.
Might want to keep trying. Yeah.
Yeah.
Any age can do it. ACOG, American College of Obstetrics and Gynecology, has a statement online saying it's safe for breast cancer survivors.
Yes.
There's very few people that cannot be on vulvovaginal estrogen, and it should be cheap.
Yeah, and I love how you said vulvovaginal estrogen, because a lot of people just think it's vaginal estrogen. We're preoccupied with the vagina and not with the vulva. We don't, like most people wouldn't even know the name of the vulva, right? Most people are just thinking that women are roaming around with a vagina, basically a potential space, a hole, right?
What a way to what a way to erase female sexuality is to not allow
Exactly.
these words to be even spoken on Instagram.
Exactly.
It's insane.
Yes.
The dearth of medically accurate images online. It's women are like, how do I know what normal is? And I'm like, usually you're just assume you're normal unless it itches or burns or something, and then get checked out. But most people are normal, and that's why, vulvovaginal estrogen. That's why I like the cream. I always say I have a cream bias, especially in sexually active people. That 6 o'clock spot on entrance is notoriously thin and ouchy, especially
Yes.
perimenopause, menopause, breastfeeding,
100%.
birth control. And
Yeah.
so I love getting the cream there, like skincare. And if you just happen to put a tab with Vagifem tabs up in your vagina, that skin might not be treated. I love treating the clitoris. I see plenty of clitoral atrophy and clitoral phimosis post-menopause that I just think, like, what if we just do preventative skincare? Western medicine, like, why do we wait for problems to come up? Why can't we prevent them in the first place?
Yeah, I think it's just how we're focused on the fixing of the problem, right? We're not as focused on the prevention, but it does need to be something that is a prevention focused area.
I think so.
100%. 100%. And we need to get the word out to women, and that's why I asked you to be on this podcast, because I don't care if like somebody listening to this podcast is in their 20s, 30s, whatever. Like, they need to know before the time happens, right?
That's right.
It's
Yeah.
so many women I talk to are in their 50s, 60s, and beyond, and they're like, why hasn't anybody told me this? Why is it? Or if they have heard about estrogen, it's vaginal estrogen, and they have not specifically heard that we also need to make sure that we're treating the vulva and making sure that the vulva is protected. And I like how you say that it's skincare for the vulva. That is so
It's
good.
skincare.
Yes.
I mean, women care about skincare. It's like a $6 billion industry. So I'm like, it's skincare for down there.
Exactly. That's so good. And once again, if we're looking at porn and that's where we're getting our information from, and we think that our vulva is supposed to look a certain way that we see in porn, that also gives us some like misinformation, because there's a lot of labiaplasty. There's a lot of other things that are happening, and we may not look like that. And then we don't know if there's something wrong with us, or if there's something that we need to, talk to somebody about, but then we don't necessarily even feel comfortable talking to anybody about. So I think that all the way around, this is something we need to talk about and be comfortable talking about, and make sure that women of all ages are aware of this information.
Yeah, totally. And I would just add, it's all genders, like the penises on porn are not average either, right?
Yes,
We're
yes,
like,
that's very true. That is
nobody's
very
getting
true.
an accurate representation of how things
Nobody's
work
getting
down
an
there.
accurate representation at all. That's definitely true. Okay. Yes. Um, is there anything that we didn't touch on that I want to make sure, and I love that phrase, touch on, but I want to make sure, like, if you had 5 seconds with somebody, what is it that you want to make sure that they know out of all the stuff that you talk about?
Oh, that estrogen, which is a compound, a hormone that your body naturally makes, is not trying to kill you. Like, I think we're still trying to claw back 20 years later after the
Yes,
Women's Health Initiative that
yes,
estrogen is bad. And
yes,
if you can't encourage somebody to use vaginal estrogen if they still think estrogen's trying to kill them, right?
yes.
And the FDA black box warning says on there, amongst other things, probable dementia. Probable dementia
Wow,
is
that's
what
like
the
the
FDA
farthest
black box
thing.
warning.
Yeah.
It's horrific. And so, a woman goes to her doctor. If the doctor doesn't say, I'm going to give you this product, the FDA black box warning is wrong. There
Hmm.
is no data to support that vaginal estrogen causes dementia, heart attack, stroke, like so much misinformation. But if the
Yeah.
doctor doesn't say that, I actually and I tell most people that, right? Because I know it. And this woman come back, she was so upset with me that I was trying to kill her with the vaginal estrogen. And I'm like, I'm so sorry you are believing the FDA on this, but you have to, believe me more because I'm not an expert in a lot, but I've read lots of papers on vaginal estrogen at this point.
Definitely.
It's topical. It's not going in, it's a very low dose. It's literally
Yes.
for your skin, for your bladder, for like the areas
Yes.
surrounding it. It does not go into your brain, your heart, anything like that. But going back to your question, we have to still keep chipping away at this estrogen is bad thing before we can get people to be like, oh, what can I do to help myself? Because I think, a lot of people will be like, can I just use lube? Can I just use a moisturizer? I saw this great reel on Instagram. It was somebody being like, the difference between your grandmother's homemade pasta and SpaghettiOs is like the difference between like vaginal estrogen and lube. Of
And
like, okay, the lube kind of helps. It does kind of moisturize temporarily,
right.
but it's not actually keeping these structures healthy and functional.
Exactly. Yes. Um, I was talking to somebody about using topical estrogen, and I'm very familiar with this topic. And they brought up the fact that for some women, when they first start to use it, it's like the tissue's being rejuvenated, but it can feel like a burning sensation. Like it can feel like irritated. And I was surprised by that. I'll be personal. I experienced that myself, but nobody had told me that before. So is this something that you're aware of, that you've heard of, or that you tell people that sometimes this
Yep.
feeling can happen, or what?
Yeah, and the biggest reason for it is the tissues are already so thinned, irritated, sensitive, right?
Yes.
That the cream is like kind of a little shock to the system. As that skin heals and gets stronger and gets more resilient, gets less absorptive, the cream's absolutely fine. So that tends to go away. I tell people like bear with it. That's your skin. It's like putting, something on like a sunburn, right? Like it's ouchy until it heals to the point where no, it's not ouchy anymore. If that still persists, say like 2 months in, 3 months in, then I'm like, okay, maybe you have a sensitivity or an allergy to one of the additives in the cream. We can switch products. We can go compounded, take some of the preservatives out. But by and large, this is why we're giving you estrogen, is because your skin is sensitive. It is irritated. It is more thinned. And as that heals, the product is much less bothersome.
And I just wanted to make sure that we had that part of the discussion, because I've been on estrogen for a number of years and nobody has ever told me that, right? And I've gone to different sexual health medicine people as well. And so I'm glad that that's something that you're telling everybody. And for the women out there that may have just gone to get the localized estrogen, but haven't necessarily had that discussion with somebody, I wanted to make sure that they could listen to this podcast and hear that information, because I think it's something that's important. Because I think women might stop it. They're like, "Oh, this is a burning sensation. This can't be a good thing."
Right. This can't be good for me.
Yes. Exactly. Especially with a black box warning, right? And then on top of that, it's starting to feel irritated, right?
Yeah.
So between those two things, they might be scared and just stop altogether when that is really what's needed.
Yeah, I mean, the other thing that can happen is a small risk of yeast infection early on because it is changing your microbiome, right? Like it is changing your vaginal pH. I tell people, I'm like, just back off, use a smaller amount, treat the yeast infections. Like, let's get through it. As your microbiome adjusts, you're going to be able to stay on this. But you have to get through the adjustment of your microbiome. I think the other thing that I see, and this is why I don't, so the traditional dosing is a loading dose of every day for 2 weeks and then twice a week, right? That's your traditional prescription. I don't do loading doses for 2 reasons. Number one, I think it's too confusing for the average person of like, okay, for how many weeks every day? And it's kind of messy and it burns and blah. So number one, I think it's just confusing. I just tell people twice a week till 3 days before you're dead. And then the second reason is when you do have that thinned skin, you're actually going to absorb a decent amount of product up front, and you will get women say like, I got headaches, I got some breast tenderness. They're absorbing it because it's a lot of product.
Yeah.
And so I don't want that. I don't want any systemic side effects. I don't want the phone calls. I don't want the stress for the women. So that's the other reason that I do not do a loading dose.
That's good to know. Thank you. I appreciate that. What about this thing about having estrogen and testosterone in the cream that you put on your vulva? Are more people talking about that as well?
Yeah, I mean, it's like the next step in the, like, now we're talking masterclass instead of like, vaginal estrogen is like English 101, right? Now we're getting to kind of masterclass, master's degree level stuff. So the vulva is a different organ than the vagina. The vulva has many, many androgen receptors. It's very testosterone sensitive. We can see this in hormone-mediated vestibulodynia, several other, pain conditions. And some vulvas, remember, all bodies have testosterone. I always have to kind of go back to get the education to where we can talk about this. All bodies have testosterone. When we go through perimenopause, menopause, testosterone goes down also. Right, so these vulvas can get very, very sensitive because those vulvas really need some testosterone to feel more normal, right? We don't have the level of science to like check your androgen receptor sensitivity. Like we don't know, right? So sometimes it's like, hey, I've been doing the estrogen cream, still really sensitive, or maybe I just need a little more like, I want to plump up the clitoris. I'm seeing a lot of clitoral atrophy. You can add testosterone to the product. Compounded because there's not an FDA approved combo estrogen testosterone cream. It's compounded, but especially for vulva more so than vagina. And that's where, there is an FDA product called Intrarosa or DHEA. DHEA is basically a pre-hormone that will convert to estrogen and testosterone. So DHEA is awesome. The prescription FDA approved is Intrarosa or Prasterone is what it's called. The biggest problem with it is it's pricey.
Yes.
But you either can get compounded, or if you want to go, totally cheap, you're not going to get a cream out of it. But some people will just do the over-the-counter DHEA supplements and put it in the vagina.
Oh, interesting. Okay.
So lots of different options. Again, you're getting into supplement products now. So are they regulated as well? Do you trust what's in them? All the issues that come along with supplements. But that's why DHEA can be so great for people, is because it's giving you both the estrogen and testosterone.
That makes sense. That definitely makes sense. I appreciate that. Now, I wanted to ask you one last question. Not every woman is going to be lucky enough to end up in your office. I wish we all could go there, but then you would never sleep. And the line out the door and down the road would be so far. So for the women, and I do talk a lot on this podcast about advocating for yourself, like my diamonds need to advocate for themselves. So if they were going to any doctor, and what are the things that they should have on their list to advocate for, to ask questions about, to be knowledgeable about, what would you put on the list for them?
Yeah. So I would say, hey, I'm experiencing X, Y, and Z. If you can say it and I'm not telling anybody to put words in their mouth, but if you can kind of say it in a medical way, right? Like overactive bladder, frequent urinations, frequent UTIs, dryness with sight, you're basically describing GSM.
Yeah.
I wouldn't say all doctors know what GSM is. Right?
No.
But so you're describing that there's something, so you're not going to go in and be like, I need estrogen. Like, you got to give them a reason, right? So I'm experiencing these symptoms. I've been reading a lot about menopause, and I would really like to try this vaginal estrogen product. And what I really like about that is you're suggesting what you want, and you're saying, I'm just going to try it. I'll come back in 3 months. Let's check in. Let's see if it was right for me. Most providers are going to be like, that sounds like a reasonable plan.
Okay.
I just think it's a nice approach.
Yeah, I think it's a very nice approach as well. And I think that it's important for all women to be able to advocate and understand what's going on with their body. I think too long with our bodies and just with our health and also with our sexuality and our pleasure in general, it's been handed over to other people. And I think it's something that's very important that we need to have ourselves, have authority over it, and to have ownership, right? To be like, this is my body. This is what I need to know about my body. This is what I'm asking for. And also to be aware that if for some reason the provider doesn't know or understand what you're telling them, you can always go to another provider. It doesn't necessarily end at that point.
Yeah, and you can bring in podcast episodes, right? Like, you can bring in this podcast episode. You can bring, if you're a breast cancer survivor, you can bring in the ACOG online guidelines about vaginal estrogen and its safety. The American Urologic Association is developing currently genital urinary syndrome of menopause guidelines, so that's going to be great to have. We don't have, interestingly enough, who's creating those guidelines? Urology. Gynecology has not developed GSM guidelines. So it's very cool.
It's very interesting.
Good job, urology.
Yes, definitely.
But it's so much urology, overactive bladder. Vaginal estrogen is equivalent to anticholinergics in overactive bladder.
Interesting.
Why don't urologists know that? Because those studies are published in the menopause journals.
Tell me a little bit more about that. So for the diamonds that may be dealing with overactive bladder, I know you just explained it, but explain it in terms that we can all get. So they're postmenopausal or perimenopausal, and their estrogen is lacking or gone, basically. And they're feeling like they need to urinate all the time. They're having frequency, urgency. What exactly are they having, and how does estrogen help that?
It just kind of starts out like slowly and slightly bothersome, right? Like, I just feel like I pee a little bit more than I used to, or I got this urgency, but then I go and there's not a lot there. So like, why did I have all this urgency? Getting up more at night, a little bit of leakage, stuff like that. So that's overactive bladder, urge leakage. It's called urge incontinence. And anticholinergics are kind of your classic overactive bladder medication. They're actually contraindicated in age 65 plus because there's so many stinking icky side effects with them. Probable dementia, legit, and risk of falls, things like that. Oh, so constipation, dry mouth. So they're not great meds, but what they did is they took women with OAB and they randomized them, this group to anticholinergics, this group to vaginal estrogen, and they had equal improvement. Vaginal estrogen was non-inferior.
Wow, that's pretty amazing.
And why wouldn't we restore function with the estrogen you used to have, just restoring your function versus drugging for function? Right.
And that doesn't even take into consideration all the other issues that could be going on with GSM that's not being addressed with the other medication.
Totally, yeah. Anticholinergics aren't going to prevent your urinary tract infections or help you have better lubrication with sex.
Exactly. All righty, Dr. Casperson, you are amazing, incredible, wonderful. And is there any last words, any last things, any last pearls, drops of wisdom that you would like to give our listeners here?
Yeah, I think in terms of, GSM, it is a myth. I see this a lot in menopause care. It is a myth that you have to be done with your periods before you can start taking hormones. There's many, many people who have these symptoms. They're still having periods, and their doctors say, well, you can't have this until you're done with your periods. Not true. Also, dryness in the vulva, lack of lubrication with breastfeeding, right? Vaginal estrogen works great for that. I put vaginal estrogen on some women who are on oral birth control pills, almost have like a postmenopause vulva, right? They get atrophy, just the way that the birth control pills are working on their body. It's like an estrogen blocker down there, testosterone blocker. So you're going to see some atrophy, resorption of labia minora, decreased sensitivity. So I'll put people on birth control pills on vaginal estrogen. So this isn't just a 51 plus, you've got to be done with periods, medication. It can help a lot of different people.
So good. So good. Well, Dr. Kelly Casperson, thank you so much for being on the podcast today. Thank you so much for being here. You are amazing. And where can our listeners find you if they need to find you?
My website's kellykaspersonmd.com. The podcast is You Are Not Broken. The book is You're Not Broken. Stop shooting all over your sex life.
So good. So good. Thank you so much.
Thanks for being here. Thanks for having me.
Yes, 100%. All righty.